Only there. And I'm going now at
The little ones, the grand.
the election of the independence.
You went to different places or you just stayed? Oh, yeah.
Different waiting for a few.
Good morning. I'm calling to order the Board of Health meeting, and our first item of business this morning is to review and approve the minutes from June 13th. Do I have any comments, corrections for those minutes?
I have one correction. On page 56. It's just a reference to the organization that I work with, the Children's Health Fund. It has public in front of it. That's not part of the type, part of the name. So
The word public should be struck
correct.
from the minutes. Okay. I had a handful of typos that I'll just give at a later time. Are there any other corrections? I think we need to be recorded, we have to turn this on. So may I have a vote to approve? Thank you.
Second.
All in favor, please say yes.
Aye.
And the minutes are adopted. Our next item is to look at a proposal to amend Article 13 of the New York City Health Code regarding the performance of confirmatory hepatitis C RNA testing. This was listed for public comment, and it was published on June 22nd. A public hearing was held on June 27th. Do I have a presentation on this morning? Dr. Daskalakis, do you want to present to the board and to begin by introducing yourself?
Thank you very much. Thank you very much. I'm Dimitri Daskalakis, the Deputy Commissioner for Disease Control. Thank you. Good morning, everyone. So this is the presentation around the notice to potentially adopt this change for hepatitis C testing. So just to remind you, testing for hepatitis C or HCV generally involves two steps. There's an antibody screening test, which shows whether the patient has ever been infected with the virus. And if the antibody test is positive, there's a confirmatory nucleic acid or RNA test to establish whether the individual is currently infected. This is very similar to HIV testing that is also two-step, with a serology and then subsequent tests for confirmation. If a confirmatory RNA test is not ordered at the time of the initial test, that means that the patient has to come back for repeat testing. That's different than what happens with HIV. So our amendment that we're proposing is to require confirmatory testing. That means we need to amend the health code to require laboratories to routinely perform a confirmatory RNA hepatitis C virus test when there is a positive serology or antibody test for hepatitis C. So that's really important because it helps to ensure that patients who are infected with hepatitis C are aware of their status, whether they are clear or chronically infected. That allows them to get linked to appropriate medical care and treatment expeditiously, and then hopefully get cured after starting curative therapy. Ultimately, this does two things. It improves their health, preventing some of the downstream complications of hepatitis C, and then ultimately reduces the risk of transmission as well. So a dual public health service. The Board of Health approved publication of the proposed rule on June 13, 2017. There was a public hearing held on July 27, 2017. We also received 10 comments, 3 oral, 7 written. And based on those comments, there have been no changes made to the amendment proposal that we're making today. 7 of the comments were in strong support. This included 1 hepatitis C virus peer education program supervisor, 2 hepatitis C patient educators/navigators, 1 health insurance company, 1 national laboratory, 1 local New York City hospital laboratory, and 1 hepatitis C virus advocacy group. Their comments focused on the importance of hepatitis C virus testing and the potential for the amendment to improve testing efficiency, increase diagnosis, and ultimately improve connection to care and treatment outcomes. We did receive 3 comments that were in opposition, 1 New York City laboratory and 2 national laboratories. They challenged the statistic that we gave at the June board meeting that 25% of individuals clear the virus on their own and claim the percentage is actually lower in New York City based on their experience and also anecdote. They have raised concerns regarding unnecessary RNA tests and that the proposed mandate does not advance the goal of ensuring patients are actually efficiently referred to treatment. Our response to these comments were that we actually do stand by our statistic, which is consistent with published studies. So we actually believe 25% is probably a really good gauge of what stats and what published studies are showing from the perspective of people clearing their infection or going on to chronic infection. The proposed requirement will likely, in fact, reduce the number of people who require repeat antibody tests by ensuring that patients actually receive their complete testing and diagnosis. So no longer going place to place getting testing, they'll have a definitive answer all at one time with 1 test and a reflex. While there may be some instances of repeat RNA tests, ultimately public health interests are paramount, both from a perspective of preventing downstream complications of this infection and also transmission. Another comment, laboratories raise technical laboratory implementation concerns and reimbursement concerns. So our response is based in the reality that many labs have already adopted this. So many local and national laboratories already routinely perform RNA testing on positive specimens. So this is feasible, it's being done in real time, both locally and nationally. From the perspective of reimbursement, we actually don't anticipate issues since RNA testing is consistent with the US Preventive Services Task Force and other clinical guidelines, and also based on the experience that we've heard from other laboratories that have already implemented this intervention. There was also a comment that questioned the necessity of RNA testing for end-stage renal disease patients and requested an exception specifically for these patients. They raised concerns regarding having to draw 2 specimens and the potential for wasted specimens. So a couple of important responses. There are many regimens that treat hepatitis C that end-stage renal disease patients may actually qualify for. In other words, it's really important for them to know their full HCV status, not just their serology. Additionally, we also know that many laboratories actually run the confirmatory viral load or RNA test on the same tube that the serology is drawn. So we don't foresee this being a significant amount of wasted blood in end-stage renal disease patients who will likely be screened once annually and who actually also have a lot of labs drawn routinely every dialysis session. So this is in effect 1 tube per year, potentially. And I open the floor to questions.
So this is up for adoption by the board, and it's open for question. This would require that there be reflexive RNA viral load testing on serologically positive hepatitis C specimens. Are there any questions from members of the board? Comment from Dr. Gowda?
Hi, it's really a comment. I think we're at a stage with hepatitis C where we've made dramatic advancements with the treatments available that really have major impacts on individuals as well as populations and really the future health of New York City and the future health of our country. So finding ways to work with laboratories to have this reflexive testing I think makes a lot of sense. And you're addressing the issues about feasibility with laboratories. Was an important concern, but you've shown that it's already being done. So I think there's a precedent for that, and I completely agree with the comment about ESRD patients. It's really 1 tube per year probably, and relative to the potential gains, those patients also deserve to have the benefits of identifying HCV infections and availability of treatments. So thank you for your work on this.
Thank you for your comment. Thank you for your comment.
Dr. Carroll?
I think it's a good recommendation, even for the primary care physician at all level. It's cost effective because it's one less visit if it's positive, and we can take action as soon as possible. But what amount of blood is in the tube for the end-stage renal disease that they are concerned? It's a small tube only.
Generally, an HCV serology can be run on a serum separator tube or on a red top tube with nothing in it, and ultimately it's about the same size as what they would run a comprehensive metabolic in, which they check every time they do dialysis. So it is not a significant volume of blood. The labs that use the same tube would mean that it's the same tube that runs both the serology and the RNA. So it does not add a lot of blood loss for an end-stage renal disease patient.
Any other comments or questions from the board? If not, I would like to ask for a motion to adopt. And second?
Second.
All in favor, please say yes.
Aye.
The motion is adopted unanimously. Thank you, Dr. Gospel.
Thank you.
I'd like to thank Dr. Goddard for pointing out that there's a population impact as well as an individual impact for successfully identifying and treating people with chronic hepatitis C infection. All right, the next item of the three votes to adopt this, remaining votes to adopt this morning, the next one is regarding monetary penalties. This was presented by our general counsel at the last meeting. Mr. Merrill.
All right, so if you recall, this proposal was to amend a provision in Article 3 of the Health Code, which is where the general requirements are. Specifically, it would create two new categories of enhanced penalties, the possibility of a $10,000 fine for a violation of the Health Code or a commissioner's order that resulted in serious physical injury, and a $5,000 penalty for a repeat recidivist violation of a health code or commissioner's order that was capable of causing serious physical injury. There were no public comments in response to this proposal. There were, however, a couple of questions from the board the last time we were here, and I want to follow up on those. One question, we were asked to look into how these penalties compared to other jurisdictions and other types of violations. So we did do a survey. There is, I think it says in the proposal, this is modeled after a provision in the state public health law where there is a similar $10,000 and $5,000 penalty. In terms of health code violations, we did not find other penalties in that amount in other jurisdictions throughout the country. We spoke to San Francisco. Their maximum penalty was $1,000, but that could be by day, so presumably it could get up to that range. We did a survey of that included Baltimore, Boston, Chicago, Los Angeles, Minneapolis, New Orleans, Philadelphia, to name a few of the cities we looked at. And again, the penalties ranged anywhere from $25 to $50 in Baltimore to up to $1,000 in Chicago and Boston. So the penalties were lower, but there was a recidivist enhancement in most of these cities, and some of them, including Chicago, the penalty was jail actually for repeat violations. Looking beyond health code violations, there are, we looked at DWI penalties, for instance, and they're in New York for a third time driving while intoxicated charge. The maximum penalty is $10,000, which is equivalent to here. And OSHA has penalties also that for workplace safety, which are in the range that we're talking about. Then we were asked also by the board to look into whether there was any evidence on whether penalties work. There is a theory coming out of the University of Chicago, which won a Nobel Prize by Dr. Gary Becker and Richard Posner, the law and economics. So there's a theory in law that penalties do work. Looking at the evidence, there's not hard evidence that it will work. There's very little studying of this, but where it has been looked at has been around traffic behavior. So just summarizing, there was a study by Lapolsky that was published in the Traffic Injury Report in 2007 that looked at recidivist driving behavior in Maryland and found a limited effect of fines. There was a summary by Nichols and Ross that was published in the Judicial Administrative Review that looked at DWI penalties. This was back in the 1980s. They cited anecdotally experience in New York, where New York had, when it imposed mandatory fines for DWI in 1981, reported a change in driver behavior. But this review concluded that the certainty of penalties is not well understood and not well studied, and certainly it looked to be that the certainty of penalty is more important than the fine. They did say that there was some evidence coming out of Scandinavia where there are higher penalties, and for instance in Finland, the penalties is triggered by your wealth. So you could have a $100,000 fine for speeding if you were wealthy, and that it seemed to have some effect. Another article by Schavel and Polinsky in the Harvard Law Journal followed up on Professor Becker's work and speculated that fines could work, but the optimal fine should be equal to a person's wealth, and again concluded that certainty was more important than the actual amount. And then there was an article by Weatherburn in the British Journal of Criminology, which looked at Australia fines and found no significant effect for recidivism, looking at the fine amounts that had been imposed. So I would say mixed results, not hard evidence that would work, but again, there is a theory of crime and economics that would suggest that it would work. So are there any other follow-up questions?
Well, thanks for such a detailed review. There were several members of the board who asked about this. Dr. Gowda.
Appreciate that wonderful overview, Tom. So is there a possibility with one of these large fines that it could actually put a business out of business? And especially for a smaller business that might have lower revenues, is that a possibility?
I'm not sure. Well, I just want to reiterate that this is something, even though we're giving the department the power to invoke this sanction, this is a sanction I think we're going to be extremely judicious in using.
Yeah.
So the conduct would have to be egregious.
Yeah.
And frankly, if the conduct were that egregious, I think we would consider, one, the effect on the business, and this is a maximum, not guaranteed, but if we were going to invoke the penalty on a business and put them out, it would probably be for conduct that deserved it.
Yeah. I suppose if that is the intent, one thing that comes up for me is, are we disproportionately affecting businesses that might be smaller, that have lower revenues, where businesses that have equally egregious conduct that have large revenues would be able to survive with such a fine? I suppose that's a kind of a more broad question, but that concern came up for me.
Well, I think that gets to the issue that was in at least the Harvard Law Journal, that fines should be equal to wealth, and you're right, a fine that's $10,000 probably means less to a company that has a lot of money.
Any other comments or questions? I'd like to acknowledge Pam Breyer has arrived. Thank you very much. Well, we have a full team here today. Did you have a question, or?
No, I was actually going to raise this same
Okay.
issue, yeah.
Well, if there are no further questions or comments, I'd like to request a motion to approve the proposed resolution to Article 3, General Provisions. Ms. Gill, thank you. And a second, Ms. Radlener. All in favor, please say aye.
Aye.
And the motion is approved unanimously. Thank you. We will move on now to the proposed item 4 on our agenda, the proposed resolution to amend Article 161, Animals of the New York City Health Code. Do we have a presentation on this morning?
We do.
Thank you, Mr. Merlino. If you could identify yourself for the record.
I'm Mario Merlino. I'm Mario Merlino, Assistant Commissioner for Veterinary and Pest Control Services.
Alexis Cuffey, Director of Dog Licensing.
I assume that the camera's still recording us. Yes. And we're taking notes. So we have the presentation. Thank you, Mr. Moreno. Please proceed.
Okay, so just to quickly run through the proposal, elimination of the dog tag provision. So currently the health department issues service dog tags. This is a function we took over from the ASPCA. The ASPCA likely distributed the dog tags prior to the passing of the Americans with Disability Act in the early 90s. American with Disability Act, it really renders the need for the service tags makes the service tags not needed. In fact, by us distributing the service tags, people get the erroneous idea that restaurants and other public facilities get the erroneous idea that people have to have our service tags, and animal owners end up being have a hard time accessing those facilities. So it ends up being something that prevents them from accessing using their, having their access to those facilities. So by us eliminating the service tags, we feel that it'll eliminate the confusion that the proprietors of establishments like restaurants might be having with service tags. So just to quickly go through the health code, the health code language simplifications. What we're proposing, two things, simply changing the sorry. Yeah. Two simple things. So all we're doing is instead of the phrase dog and cat, we're substituting any animal in the part of the health part of the code that talks about an animal for sale, boarding, and grooming, and that has a communicable disease. So preventing an animal that has a communicable disease being for sale, boarding, or grooming. The other change there is, and this is the third bullet, sorry, I skipped to the bottom, but the other change there is the adding parasites to the list of communicable diseases, that you're not allowed to sell an animal that has parasites. Okay, and then the middle bullet there is we're changing one word in the section of the health code that talks about what you can't have a kennel in, right? So you're not allowed to, right now, and it's just a clarification, it's not a change in the health code. We're clarifying that you're not allowed to have a kennel in currently says room, we're changing that to dwelling, to make it clear that you're not allowed to have a kennel in your house. Okay. So we did have a hearing in June 22nd. We did try to reach out to as many interested parties, potentially interested parties as we could. We sent this to everybody that has a permit from us, Article 161 permit, that includes all the pet shops and groomers and trainers. We also sent it to the government officials, including there's also people with disabilities and Commission on Human Rights, and the web-based businesses that were interested in the kenneling change clarification. 2 people testified at the hearing. We did get 6 written comments. On the elimination of the service dog tag, we got all the comments were in support, and they were from the Mayor's Office of People with Disabilities, and they did feel that it would eliminate the misconception that I talked about earlier, and actually help people that have service animals to use the service animals and widen the use of service animals. So we're not recommending any changes to the proposal. And the comments on the only other comments were on the proposal to the part of the code about the kennel definition. So again, changing room to dwelling. So one individual talked about object to the current prohibition on home-based animal boarding. One of the web-based companies that matches home-based boarding with pet owners objected to the current prohibition and requested that the board delay consideration of their proposal. One permitted kennel owner supported the proposal and wrote their comments opposed home-based boarding basically on safety grounds. And one pet-related web business supported the proposal. So we're not recommending changes because the proposal, again, to delay the vote or change it, we're not actually recommending a change to the code. It's just a clarification. So even if we delayed the vote or didn't approve the vote, it wouldn't change the code. And we feel that since the code, the change that we're requesting is a clarification, it'll actually be helpful. That's it for me. Thank you.
Thank you. Are there any questions or comments from the board on the presentation? There are 3 parts to this proposal. If you could just specify which part you're addressing in your question.
Thank you for your presentation and for your excellent work on this, to both of you. My question has to do with a couple of the comments that we read in the public testimony where the 2 comments, one from Rover, the company that I guess does, for lack of a better word, peer-to-peer linking pet owners with those who can look after their pets, and then another from an individual who does pet sitting. They seem to misunderstand that this was focusing on individual pet sitting services. Could you clarify that, please? Individuals who might walk a dog or do individual pet sitting.
I think, as I said, I think one of the things that they might have misunderstood was that what we proposed was a clarification. That's kind of what I got out of their comments, was they felt like that that we were changing the code and making the code stricter or making a change and doing something that changing enforcement, and that just isn't true. We're not enforcing any differently, and this change won't result in any different enforcement. So that's kind of what I know I'm not quite being responsive to your question, but it's hard to tell what they, to me, it's hard to tell what they want. I think there is a desire out there for regulating some of these entities differently. I know dog walking currently, is not regulated per se by us. There is no permit for dog walking, but I know people have expressed outside this common process that it should be or shouldn't be, but.
If I could jump in, I think it was characterized by Rover that this would prevent you from leaving your dog with your neighbor, and that's not true. This applies to people who take in dogs for a fee. So you can leave your cat with your neighbor. You can have someone come into your house and take care of your cat. You can pay the cat sitter to come into your house. So this is when you take in a dog or any animal into your apartment for a fee. That's what this kid said, and that was what was mischaracterized by Rover.
What was that the question? Yeah. We're not trying to ban. This change certainly doesn't ban dog sitting, and we haven't in the past
So
cracked down or banned dog sitting.
do you feel like that was clear to the commenters, that they misinterpreted the intent of this change?
If it wasn't clear to commenters at the hearing, let me just say it again. We are not trying to ban dog sitting, and either do the change or we weren't in the past.
Thank you.
Thank you. Dr. Richardson.
So perhaps this is a question for Tom, but I also am a little unclear about exactly all of the situations to which the current code applies. I understand that there's no prohibition about hiring someone to give services to your dog in your home, but I understand there are arrangements now where you might find on one of these web-based platforms someone who would take care of your dog in their home for short periods. Someone half-jokingly earlier said it's like Airbnb for dogs. Is that regulated by the code? If someone I don't know I now pay for them to board my dog for a week while I'm on vacation, does that fall within the jurisdiction of the department, such an arrangement?
Our current position is you would need, so if you routinely take in dogs for pay, you would need to get a kennel permit. That's our current position.
So routinely is the key. If you did it occasionally, that might not.
Yeah, I mean,
you could see the gray area.
I think there's a.
Tom, can you help
Yeah.
us?
Yeah, I think we're kind of reading the routinely in there. The bottom line is if you take a dog in, you're a kennel under the health code, under the zoning laws, and there's no provision currently in any law about routinely or not, but although I don't think we're gonna go out and like if you like pay the girl next door $20 to take care of your cat, we're not coming down on them. But there's no provision on that, and there's no provision in either the zoning law about the amount of dogs. That may be something that changes, but currently, if you bring a pet into your into your apartment, actually you shouldn't be bringing it into your apartment, but into your building, you're a kennel.
Dr. Carroll.
Let's see if I understood well. If that a comment on one of the commenter that less than 4 dogs, is there any difference between 4 or 3 or 2 or 1? As far as I understand, any dog owner has to have the veterinarian examination and visit once a year with the vaccination, etc. That's it's part of the picture as far as I understand. Yes?
Yeah, I mean, those are requirements for a kennel. So that's what we're saying. I think all those things are important safety features of our kennel permit, and so that's exactly right, I think. And again, you're right. The number of animals wouldn't matter. So if somebody's operating as a kennel, then whether they have fewer animals or more animals. I know that was one of the proposals. One of the things that in the comments was if, hey, there could be some sort of safe harbor if there's under a certain number of dogs. So that's an idea. Obviously, that's not what we proposed, and that's not in the scope of the change that we haven't proposed here in the health code. But I think the way the code's currently written, any number of animals you would need a kennel and permit. And once you get a kennel permit, you're able to have as many animals as you want in your kennel. So that's the thing. And again, too, there's no prohibition for dog owners. There's no prohibition for dog owners. You can have as many animals as you want in your home, owned animals.
Ms. Bryan.
I will say, I for the discussion will come to an end, but soon. But I'm sorry. When Peggy Hamburg was health commissioner, she was wont to say that she received more mail from people about animals than she ever did about humans. And I think
I would concur with that
yes.
assessment.
I am surprised that 100, 200 people didn't come to this hearing. But I don't know. I think we've sort of exhausted the questions, but maybe I'm wrong.
Well, thank you for that, but I think that the board was seeking clarification on the limits of what has been described as dog sitting. And I'm hopeful that the board has received that clarification, that sort of private kenneling of animals is not permitted under the current or with the modification of language from room to dwelling. Dr. Gowda.
I just wanted to ask one more question. So currently under the regulations, it is against the regulation to basically bring in pets into your own home to board them. You would be a kennel. I think one of the comments said we would be willing to work with the Board of Health to figure out mechanisms where our current members in whatever organization that is could then develop the licensure to become a kennel. Is that something that is realistic for many people to kind of meet those criteria, or is that really something that businesses can be able to do?
Thank you, Dr. Gowda. If you could introduce yourself.
Good morning, Corinne Schiff. I'm the Deputy Commissioner for Environmental Health, and we have received further comments from Grover, who came to the public hearing, and they have presented a proposal. I believe they're also perhaps working with the City Council, so there is some additional proposals that are floating around, but our proposal was just for this minor word clarification, and the comments really didn't address that proposal that we have made to the board, and so any additional changes to the substance of what is now required by the board in the health code is for another day, really.
And I would point out that if we're going to talk about, there are other laws involved here, like zoning laws, so it may be something that's better fixed legislatively than with health code.
All right, Ms. Breyer, your comment stands. If there are no further comments or questions from the board, I would like to ask for a motion to approve the proposed resolution to amend Article 161.
So moved.
Second from Ms. Naowith. All in favor, please say aye.
Aye.
Any opposed or abstentions? No. So the motion passes unanimously. Thank you very much to the team. for your careful work on this. All right, we're now moving to the last of the proposed resolutions for the board's consideration for adoption, which is a proposal to amend Article 47 of Child Care Services. And we have the team here. I just would note that this will be Mr. Krishula's final presentation of many that he's made over the years to the Board of Health, because he will be leaving the Health Department, but not city government. Thank you for being here to finish this today, I hope, Mr. Krishula.
I hope so too, but thank you very much, Richard. So, good morning, Frank Krishula, Assistant Commissioner for the Bureau of Child Care.
I'm Untitled Chapter Director for Early Childhood Development, Bureau of Child Care.
And we're here today seeking the board's approval of an amendment to Article 47 regarding drop-off of child care services in homeless shelters, family homeless shelters. So we did have our public comment period, and we received a number of comments from homeless advocates and as well as providers. In general, they supported the regulation of drop-off shelter-based care, but they did make a number of suggested revisions regarding our original proposal on the limitation on the use of drop-off services, the role of the child care liaison, as well as staff qualifications and facilities. So we'll just walk through some of that and inform you as to the changes that we made based on the comment. So if you recall, the original proposal was to limit the drop-off care to 10 hours per week per child. As you'd imagine, we received many comments suggesting that the strict time constraints on entering a shelter environment for families would limit their ability to sort of adjust to the shelter and find childcare for their children. Also that some of the families are deemed ineligible for subsidized childcare, and of course cannot afford full-time care. Also pointed out was a limited capacity for infants and toddlers, just throughout the system, the whole center system in New York City. The fact that families would need the extended drop-off hours if they happen to work at night. And one comment involved the shelter environment intended to be sort of temporary for families, and that requiring this rapid enrollment in long-term care presumes a longer shelter stay. So our response to the limit on the drop-off service is that we would have no limit for the first 90 days that a family enters a family shelter, giving them the time to adjust and find care for their children in 20 hours a week thereafter for each child. A lot of that was based on surveys and data, surveys conducted by ourselves, as well as data provided by DHS and ACS, and as well as WIN. If a family needs or doesn't qualify for a subsidy for childcare, they could request a modification. The shelter could, on their behalf, request a modification of the code, establish that they do not qualify, and the department would then waive the cap for that specific family. In addition, if a shelter does not have available childcare capacity within that half-mile radius, the same could be done. They can request a modification, and we would do our assessment to make sure that capacity is not available, and we would approve the modification request. Based on the data we have, most of the shelters do have within a half-mile radius a number of early learn sites, a number of private sites, and at the time that the survey was done, they do appear to have spare capacity. But the survey was done in August when many sort of have low enrollment. So this is very sort of point-in-time data, and we'll just have to assess any modification requests that we receive for for the cap on time. In addition to all of that, if one of our programs are very high quality and they want to seek a Article 47 childcare permit, they could do so, and they would have no cap on the service that they provide. We also received a number of comments about liaison role, and again, if you recall, this is the individual at the shelter that would assist families upon intake in finding childcare, letting them know what their options are, assisting them with, obtaining subsidy. Very supportive comments that, in fact, they asked that we add an additional role of making referrals to the Committee on Preschool Special Education for kids that need educational assistance. So we have, in fact, added that role. And we're also going to be requiring record keeping around the number of families entering the shelter, the number of children in residence under the age of 6 years, referrals made to licensed childcare facilities, and the number of children enrolled in the childcare facilities. I think that will give everybody a good sense of the demand and need and what exactly we have, happening once a family enters a shelter. We were also asked to allow experience as substitute for a BA degree or BS degree for the child care liaison. We haven't changed from the original proposal. We'll maintain that. 2 reasons. But one, DHS, through its contracting, does provide early care and educational liaisons as well as client care coordinators. Both of those positions require a BA. Many of them have master's degrees. And if a facility does have a very high qualified person with a lot of experience, and they can use, again, the modification clause in the code, and the department would consider that individual. So we would mod that on a case by case. And we also asked if we would grandfather the existing physical plant requirements in the health code, and we have not made any change. The physical plant requirements speak directly to the health and safety of children, and it's not just the health code, it's fire code, it's building code, and we think it's very important that programs maintain that level of safety for kids. So I'm happy to take any questions you may have.
Thank you, Mr. Petrillo. The presentation is open for questions and comments. Ms. Redland.
Well, first of all, I, as people know, I was very concerned about the initial proposal that was discussed at the last meeting, and I really want to recognize that the Department of Health has done a lot to consider the comments that were provided by homeless shelter facilities and advocacy groups, and I'm impressed with the modifications that have been made. I have a few questions about some of the implementation and or waiver requests. It's based on, as we've seen from the comments, there are 167 shelters operating, Tier 2 shelters operating currently in the city, and only 25 of them have licensed daycare facilities now, and 43 are the unlicensed drop-off centers, and I think that's the focus of this regulation, those 43 unlicensed drop-off centers. So what we're now asking the shelters to do is bring those unlicensed drop-off centers to the same compliance as child care facilities in general. Is that correct?
As far as their physical plant requirements, yes.
Okay. So my concern is that, how do we feel about the ability of these 47 shelters to meet these current requirements? And do you think that by holding the physical plant requirements so strict, that many of these facilities will have to close? So I certainly am in support of health and safety for children and want to endorse that concept, but I'm just wondering if there's some process for evaluating these on-site shelter facilities with a a bit of grandfathering in or waiver requirements around smaller requirements, whether it's, the number of sinks or the number of bathrooms, that kind of thing, because I'm just concerned that many of these facilities that are so helpful for homeless families will not be able to meet the physical plant requirements and will be forced to close.
Sure. So at the beginning of this process, we had conducted what we call viability inspections of all of these facilities. So we do have somewhat of a sense of the type of work that needs to be done and the number of sites that didn't have, things like secondary egress. Process-wise, if this should all be approved, it would go into effect about 30 days from now. We will work with all of these sites in doing further assessment along with DHS and ACS and fire and buildings to do a complete assessment of the need and the cost of coming up to code. None will be considered sort of operating illegally and shut down immediately. We will only get to that point if it's clear that it's so costly that they couldn't possibly comply with the code, or because of the configuration of the building, they can't come into compliance. I mean, there is some room for waiving minor stuff, but again, it's not just a waiver that would be issued by health. We have fire department requirements, we have building department requirements. I think most of these shelters have a residential C of O that'll need to be converted to a C of O for childcare. We've had prelim discussions with buildings around that. Now, once they have a better sense of what the shelters look like, they may come up with another solution. We've always found them to be reasonable when they can be reasonable. But the bottom line is, if it's unsafe for children, there's only so much we're going to be able to, sort of waive. Also, none of the sites have to be in compliance with any of these new regulations. They'll actually have the permit in hand, so health will not immediately just issue a permit. We will be working with them during the application process to come into compliance with all of this. Will some have to close? I don't know, but my guess would be yes. We found a very small number. Do you remember on the egress?
There are currently only 37 sites with drop-off services of 43 sites that are Tier 2 certified or have a contract with the Department of Homeless Services. I don't recall the actual figure for the number of sites with no secondary egress, but we have the assurances of the other city agencies that they are working with these programs to come up to the prospective code that they will have to comply with.
Are there additional funds for the shelters to be able to use to meet these new requirements if they want to,
Yeah, well, of course, we don't control the funding, but in our meetings with DHS, we've been told that, yes, the additional funding will be made available.
And I do want to clarify, the second means of egress and the basic safety requirements, of course, I understand. I am just, wondering, there are 40 pages of regulations relative to childcare facilities, and I'm just, wondering about, the need to be in compliance with every single one of them. I mean, I would like to balance a little bit the importance of having these drop-off facilities for homeless families, if at all possible.
Right, and we could use universal pre-K as sort of a model for how we went about permitting. During UPK, it was an enormous expansion. We had everyone in the room. We had fire in the room, buildings in the room, ourselves, DOE. And when we needed to come up with creative solutions, we came up with creative solutions. So again, bottom line, health and safety, but if there's something that we could be reasonable on, I found the other agencies all to sort of pull together and try to come up with, solutions. So.
Thank you.
Did you have a comment or questions, Gil, or did it?
No, it was answering the last question, thanks.
Dr. Klitzman.
Hi, good morning. I just share my colleagues' appreciation of your willingness to listen to all the comments and to reflect on how we can get to that sweet spot of meeting the needs of children whose families are homeless, as well as complying with health and safety regs. I have two questions for you. The first one, it has to do with the qualifications of a child supervisor. So under section 47.18 on page 13, you say that in determining child care liaison qualifications, the department may accept documentation from schools, colleges, and universities approved by the state education department. But with respect to the next section, a child supervisor in a family shelter-based drop-off child supervision program must have a minimum of an associate's degree in various fields or a related degree that is approved by the department or a child development associate certification. So I'm putting my education hat on here, and typically it is the responsibility and the expertise of the state education department to evaluate and make a determination about educational facilities, and I'm just concerned as whether it would make more sense to extend that to the child supervisor as well as the child liaison. Does the Department of Health and Mental Hygiene really want to take that responsibility on of evaluating schools and universities, or is that something better left to the State Department of Education?
No, I think it is better left to state DOE. I guess I'll have a look at that language. Can we just replicate it for the supervisor, Tom? Or?
So if we make a change today, it requires a unanimous vote of the board making the change. With the capital requirement.
Yeah, so I guess I would propose, and I'll look to the,
Yes, go ahead.
please correct me if this is not the correct format, but I would like to propose a friendly amendment to make that provision consistent so that it is the responsibility of the State Department of Education to evaluate the qualifications of the child supervisor as well as the child care liaison.
I think that's right. You make that amendment, there's a second, you vote on that, if it's unanimous, we can make a change.
Second.
So do we have a motion, we have a second, do we have any discussion on the motion?
Yeah, my question is the wording in subsection 3 that to which you refer seems to be permissive rather than imperative. It says the department may accept documentation from schools, et cetera, approved. It doesn't say that the documentation that's accepted must be approved by state DOE. So, and I'm not questioning the wording, but it doesn't seem to me that it is assuring what you're alluding to. Because it's simply that you may accept that documentation. Or you may accept documentation that they have not approved. I mean, that's the way I'm reading the third paragraph, subparagraph. Is that correct, Tom?
I'm not sure. But I think it's confusing.
So we would not accept documentation that state DOE has not approved. I mean, that's not something we've ever done.
Right.
I think it's just a matter of cleaning up the language a bit.
Yeah.
And that would, are there further, I think I need to ask for some guidance from our general counsel on this. We want to do this in accordance with our standard practice. And at the moment, it doesn't look like we have language that we're confident is in accordance with that practice.
Yeah, so I
For
think.
both roles. Is that the problem, that it should apply to the child supervisor role as well as the child liaison?
Right, and my point is just that it just seems like the Department of Education is the agency charged with that function, and to put the Department of Health in the role of evaluating educational credentials doesn't seem appropriate to me.
Do we, I mean, we have similar degrees, similar educational requirements for the child supervisor, for the family shelter, drop-off centers, for other child care sites. What language do we use there, Frank?
I'm gonna have to take a look, but I think it's similar to what we have in the child supervisor language in some spots. And then for the educational director, I think it's consistent with the liaison. So we may have to just propose another revision to clean that up. We can do that maybe at a later date. Unless you think we can do it today, that would be,
Again, because of capital, we need, if we can come up with language right now and everybody approves of it, we can make the change today. But so I guess, does somebody have a proposal of exact language?
I'm afraid I don't feel quite capable of
Yeah.
doing the drafting on the spot.
So-
Yeah, I'm a little worried about
Okay.
the idea of us trying to come up with language on the spot. I think the clear intention of the board, and I don't know if we need to actually vote on the amendment, is I think Dr. Klitzman's point is well taken, and that the same type of language should be in both provisions, both for the liaison and the child supervisor, and that it should make it clear that the Department of Health and Mental Hygiene is going to rely upon the expertise of the Department of Education in identifying appropriate educational qualifications for these roles. But I don't think we should be the ones drafting the language to assure that, it's legally sufficient. But I think that is our intent, and I don't want to hold up the substantive issues that are before us today, but it does seem as though there might need to be some look at the entire section to make sure all of the language meets this intended suggestion from the board.
So, can I just ask our general counsel, is it sufficient for the board to vote on the intent of the language, or do they need to vote on the specific language?
The intent is the intent, and I certainly think that I think what you're saying, Dr. Richardson, is certainly in making approval under B here, they would defer, and I think, Frank, that's right, you would defer to SDOE, right? So I think that is the intent. The intent here is not for the department to substitute its judgment for the professional qualifications of SDOE. That's absolutely right, and that will be the intent, and that would be how this will be interpreted. We can go forward on that, and the intent is, part of the discussion is the intent of
So
the rule.
Tom, I'm sorry, just.
So the intent of the rule is not barred by the written language at the moment.
So does that mean that in number 3, instead of saying may accept, it would say must,
I'm sure we don't want to say.
yeah.
No, I don't think it's that.
Must have a, okay, no.
I think that we're now really talking about subsection B, and which doesn't contain a reference to state education department.
Yeah, okay.
And the presumption here is that the standard practice of the health department in reviewing documentation of educational accomplishment is to reference the standards of the State Department of Education. So the question is, does the current language permit us to continue to meet that practice? And will the board be satisfied with the presumption that in assessing educational qualifications, the department references the standards used by the Department of Education, from the State Department of Education?
So I think, just to step back for 1 second, that the context is to try to create alignment across all of the categories of childcare for children, regardless of where they live. So to the extent that the language reflects existing, language in the existing regulation that could be checked, but to me, when I read it, the difference in the positions is that one has a CDA on top of an education, a college or associate's degree, and the other has to have a degree from an accredited institution of some sort. I don't know what the code says now, but this language of approved by the department is the sticking point. So, and all the rest of it is fine. It's the issue about approved by the department. So if we can figure out whether that is consistent with existing code and the whole child care system is based on the same language, that's one thing. And the other is, if it's just boilerplate that we've been using in all of our child care regulations, then that's something else to think about, but it shouldn't stop us from moving forward, in my opinion.
Dr. Richardson, then I'm going to turn to our general counsel to resolve this matter.
Yeah, just to raise a slightly different issue, so again, looking at subsection B, it would appear to say that either you have an associate's degree or a related degree or a CDA certification. So if you have the certification, you do not need the degree. And is this child development associate certification a specific certification and by whom?
Yes, so CUNY, for example, issues CDAs, and they're not a replacement for a college degree per se, but in the way in which it is framed here, it can be in place of an associate's degree. So it's accepted as a credential, same as the associate's degree as described in the qualification.
And do the State Department of Education standards reference CDAs, or is?
CDAs are regulated, and CDAs, there are credit-bearing CDAs, for example, that count towards a higher degree.
Okay.
One more comment about it.
Yes, yeah.
CDAs are used all over the country as a certification for early childhood expertise. It helps people with a regular teaching degree or other degree get the expertise they need in early childhood development and education. So it's a legitimate thing, even though we don't often talk about it.
All right, I think we may have sort of talked our ways around in a circle here. Let me see if I can summarize it and see if there's agreement that the section B, as it stands now, is not harmed by the lack of reference to the state education department. That it stands on its own as a credentialing process, one that is recognized and regulated by the state education department. So I think that we can assure Dr. Putzman that the department is not the purveyor of standards for the CDA or the associate's degree, and that that the section as it stands is not harmed by the lack of reference, and we can proceed with our deliberations on the proposal. Have I got that right? Let me ask the general counsel.
I agree with that.
The general counsel agrees. We have a motion on the floor, so we need to figure out what to do with it. Unless it's withdrawn. Are you, okay.
If it's still active, then there's a vote, and if it's unanimous, then
I just need another minute. to
Okay.
read it, because, I have to do everything at least twice. So again, I do want to, not hold this up. Can I just ask you, Tom, to explain why you think it's not necessary to modify this in order to achieve the goal that we all agree on here?
Well, one, I don't think the child supervisor is a profession per se regulated by the state. I may be wrong in that. Correct.
No, it's the degree, not the.
Right. So,
Educational.
and absolutely, the degree requirements are regulated by SDOE. But then the department, in terms of looking at what degree, which is regulated by SDOE and defined by SDOE, it satisfies that, a person in that title should hold, it's not like we're gonna create a new associate's degree. We're gonna look at the associate's degrees that are, created by the state and necessarily look at what SDOE has said. But then in our experience, we may, I can't think of other degrees that might be applicable, but there may be another associate's degree that in the experience of the department satisfies the requirements to be in a child supervisor role. But SDOE would define what qualifications are for the degree, but they don't say you need that degree to have this role.
So it's really the job qualifications that are being determined by the department and not the integrity of the degree.
I think I'm still having trouble seeing why the part that says or related degree that is approved by the department should not be left to the state education department, but I don't want to hold this up, so I can withdraw my motion and, abstain.
If child supervisor were a profession regulated by the state, I would agree with you, but it's not. But it's, and so then it's a question of, we want somebody with an associate's degree in that position. And associate's degrees are defined by the state, the education side. It's not like we're gonna create a new degree. If that were the case, I would agree with you, but we're gonna look at degrees that are available, and then somebody will come with a degree that's granted by a degree.
Yes, Gail, do you want to take a?
I'm gonna try. So the health department isn't going to subordinate the state as the certifying entity for what's a degree, a college degree. The issue is which degrees can apply in these cases. So it's flexible language. So for example, if I had a degree in culinary arts, I'm not necessarily going to be able to work in a child care program. If I have a CBA or if I want to work in a kitchen, yes, but I should not necessarily be a supervisor. So there has to be a certain amount of discretion when the department looks at the various, at the educational credential of the individual, because it has bearing on the work. So there's a relationship between their educational credential and the scope of work for which they'll be responsible. It's not a substitution for the fact that they graduated and they are licensed in their profession, but it may not be a relevant germane degree for this work. I don't know if I'm helping or making it worse.
Okay. No, I think that was helpful. We're trying to distinguish, I think, between qualifications that fall within the job description and qualifications that are recognized as legitimate markers of educational attainment. The latter being a responsibility of the state education department.
Okay, I'll withdraw my motion.
All right, thank you. Are there further discussion about the proposed changes to this rule? Yes.
Just one. I think as we see the significant shifts in early childhood education and care in the city, and we move towards a more coordinated system, there are going to be a number of things that are going to surface that we haven't really expected. I think that the compromise that you all have reached is a good one, and it provides a lot of flexibility at the point at which homeless families are in most crisis. I also want to just say for the record that half of the shelter system does not have on-site drop-off care, and those families are okay. And to the extent that we can then regulate the services that are provided on-site, that's also very important and very good, but I do want to point out that not every shelter has this capacity, so there are accommodations that are made throughout the system. But just as an absolute sort of standard point, we need to have one unified childcare system, an early education system in the city, and to the extent that we keep marching there, step by step, I think it's really terrific, and applaud all the work, even though it's very arcane. So thank you for that.
I have a comment.
Yes.
I think I agree with the importance of having consistent standards for childcare, but I do also still want to say that different circumstances that families live in require different kinds of support services to make their lives work. And I'm not sure that the families that are in Tier 2 shelters without drop-in sites are okay. I'm not sure that their lives work as well in terms of getting themselves back to a stable housing situation. The average length of stay for families is over a year in Tier 2 shelters, and depending on the capacities of the families in the support network in the shelters, that experience can vary widely. So my concern is a little bit about what happens to the 37 drop-in sites that are currently operational and providing support to families. Is there a way that the board asks for updates about the impact of a particular
Absolutely.
regulation change? I would
Absolutely.
like to ask for that.
We would welcome that.
So at some point, 3 months from now, 6 months from now, if we could have a report on what the status was of those 37 sites or what the other shelters decided to do relative to that.
Yes, duly noted, and we will undertake to report back to you.
Thank you.
Are there any further comments or questions? I should just note that the intention of the department in addressing this issue was to both meet the needs of families that are in very difficult circumstances at a very difficult time in the family's life, and also ensure that we don't use the difficulty of families as an opening to justifying a level of service that we wouldn't want to see other children have. So we've sought to balance the flexibility that families need as they enter shelter. The first 90 days, they will have an uncapped access to the child supervision drop-off sites, with the reality that this is not the best level of child care that we want to see for children in our shelters or in our city. So while being mindful of the risk potentially to some of the sites, we're also hopeful that this exercise will encourage others to apply for and obtain full Article 47 child care status. And that may also, I hope, be an outcome that we'll report to you, Ms. Redlener. So with that final comment from me, and with thanks to Dr. Klitzman for her careful reading of the rule and that conversation, may I have a motion from the committee to adopt?
Second.
So moved by Ms. Redlener, seconded by Ms. Gill. May I have a vote? All in favor, please say aye.
Aye.
Are there any abstentions? Any no votes? The motion passes unanimously. Thank you to the program.
Thank you very much, everyone.
And best of luck to you, Mr. Pashura.
If I may just thank the board, for helping us craft these regulations over all these number of years. It's really useful for at least the child care program to get the feedback and have you sort of poke holes and question, what we're trying to do with regulation. When you're in a room with your staff developing this sort of stuff, it all sounds good after a while, and we think we're just doing this terrific job. So, having it vetted by the board is extremely, extremely helpful. So, thank you very much.
Thank you.
Thank you. Good luck.
Thank you. I really do want to note that this is a display of the democratic process offered by the Board of Health. The fact that every proposal is presented for public feedback, and that we have an astute and critical board that also challenges us. All right, with that, we will move on to the next item, which is for consideration for approval for publication. So this is moving on from adoption to a review of proposals. This one is to amend Article 11, reportable diseases and conditions, and Article 13 of laboratories for the New York City Health Code. Dr. Daskalakis, if you could reintroduce yourself to the board.
Thank you. Thank you again. I'm Dmitry Daskalakis, the Deputy Commissioner for Disease Control. Thank you for hearing me again. So as you've heard, this is a proposal to amend Health Code Articles 11 and 13 of disease surveillance. To remind you, Article 11 regulates disease surveillance and control activities, including what diseases must be reported to the health department. Article 13 regulates the manner in which lab tests must be performed and also reported to the health department. There are two proposals within this presentation. The proposal is to first amend Article 13 to require laboratories to report all hepatitis B DNA tests, including negative results. As a frame of reference, this would mirror what happens with HIV and hepatitis C, where both negative and positive results are reported. Currently, only positive DNA results must be reported. The second is to amend Article 11 to add carbapenemase-resistant Enterobacteriaceae, CRE, to a list of reportable diseases. This is only a laboratory report requirement. So first, let's talk about hepatitis B DNA test reporting. The number of hepatitis B HBV cases is rising nationally and also in New York City. We have more than 100,000 New Yorkers who are estimated to be living with chronic hepatitis B infection in the city. In 2016, almost 8,500 new cases were diagnosed, and again, for frame of reference, that's about 3 times the number of new diagnoses of HIV. That's an increase of 18.8% since 2013. Part of that is due to a change in definition of case. Chronic hepatitis B can lead to serious health issues. That includes cirrhosis and liver cancer. It is an oncogenic virus. All infected individuals require care and monitoring, and some require antiviral medications. Just to review hepatitis B, the progress of infection in some people. So after infection, about 90% of infants, or 5 to 10% of adults, will progress to chronic infection, where they have ongoing viremia. About 15 to 40% develop serious liver disease, and 25% will go on to cirrhosis. About 5% will move on to liver cancer. Some percentage, like I said, about many will recover. Infants are not as lucky from the perspective of a hepatitis B infection. So hepatitis B DNA testing is performed on individuals who are infected with HBV, which means they have other serologic evidence of an infection. That measures viral load and whether the patient has chronic or active hepatitis B infection. For patients with chronic hepatitis B, DNA tests provide really important information regarding infectiousness, treatment eligibility, and risk for development of liver cancer. If one were to look at guidelines for treating hepatitis B, viral load actually figures in the calculus for every decision. For patients being treated for HBV, DNA tests are also important in monitoring suppression. So again, HBV is not a curable, for the most part, disease unless you use interferon. But for other oral drugs that are used, you do suppress the virus and monitor HBV virus to make sure that people are being adequately treated or that they've not developed resistance. So the idea that we have is to require reporting of all HBV DNA test results, again, to mirror some other viral infections of public health concern. HIV and hepatitis C are the examples. This will allow us to create, in effect, a continuum of care that is really based on data from the perspective of what's happening with HBV. It will allow us to estimate the proportion of New Yorkers infected with HBV who are appropriately tested and also linked to care. By allowing us to have a better view of HBV throughout the city, it will allow us, like we do with our continua of care with HIV and Hep C, to identify gaps in access to care. Additionally, we'll be able to better target interventions to increase linkage to care and improve provider knowledge of HBV testing and treatment guidelines. Additionally, increasing our ability to monitor the details of hepatitis B will allow us to decrease hepatitis B-related morbidity and mortality. Moving on to a completely different organism, carbapenem-resistant, or group of organisms, carbapenem-resistant Enterobacteriaceae reporting, or CRE. CRE is a family of bacteria that are difficult to treat because they have high levels of resistance to many antibiotics, including carbapenem antibiotics such as imipenem and meropenem. Carbapenem antibiotics are usually the last line of treatment for infections caused by highly resistant bacteria. These infections, CRE, are common in hospitals, nursing homes, and other healthcare settings. CRE is an urgent threat, and the CDC has designated CRE as an urgent threat, the highest threat level in its list of antibiotic-resistant threats in the United States. The emergence and dissemination of carbapenem resistance among Enterobacteriaceae in the U.S. represents a serious threat to public health. These organisms cause infections that are associated with high mortality rates and that have the potential to spread widely. Decreasing the impact of these organisms will require a coordinated effort involving all stakeholders, including healthcare facilities and providers, public health, and industry. So this is a quote directly from the CDC document that identifies this CRE as an urgent threat. So what do we know about CRE in New York? In 2015, hospitals in New York State reported about 3,600 cases of CRE via the CDC's National Healthcare Safety Network, or NHSN. About 1,700 of these were reported by the 51 participating New York City facilities. It's important to note that only hospitals submit CRE data to this system. The number of CRE infections in New York City is likely significantly larger than what this picture paints. So the concept is that we mandate reporting of CRE by laboratories. This will be important because it provides vital epidemiologic information regarding the incidence and evolution of CRE. It will help us identify new strains, clusters, and outbreaks of this infection, enable the health department to help ensure appropriate infection control precautions, and it is closely aligned with the July 27th release of the Council of State and Territorial Epidemiologists guidelines that say that we should be doing surveillance of this organism. That's the end of my presentation. Thank you.
Thank you. Open for questions. Ms. Bryant.
So then, hospitals, nursing homes, healthcare facilities, ambulatory ones that happen to have labs will continue to report as they do now. And in addition, proprietary, I think they're all proprietary labs, that have the, get something to evaluate on behalf of another institution will also report. And so presumably the regulations will be clear enough that you won't get duplicates, as in the hospital sends something to you when they get a result, and the lab that the hospital sent it to, right? So that won't be an issue, you think, right?
So that is, that's correct. Mainly around the fact that our surveillance system, our lab reporting surveillance system, one of its very significant features is working on deduplicating results in individuals. So this will be information that we will get through that same mechanism, through lab reporting, and so it will go through a deduplicating process so we're not getting repeats. So generally, I think people will be sending, if they have a contract lab, they're going to send their labs to contract labs.
Yeah.
If they have an in-house lab or a hospital lab they
Yeah.
use, it should still go the same pathway.
Great.
Great, thank you.
Good idea.
Any other questions or comments, Dr. Richardson?
So first I want to thank you for addressing CRE, which I do think is really an alarming and under-recognized threat. And so I applaud the department for taking action on that. I do have a question though about the first item. And what do we know about the transmittability of Hep B as a function of viral load?
So there are data that higher viral loads do transmit better. We don't have that same sort of threshold that we do for HIV. So if you were to look at the HIV literature, there's a number, 1,500 copies per mil, that is associated as a threshold for where it's very unlikely for transmission. We don't know as much about hepatitis B. Also, the viral load dynamics of hepatitis B are completely different than HIV. So suppression in HIV will happen in 12 months. Sometimes HBV suppression may take up to 6. And so it's a different creature. But we do think that higher viral loads, there are data that higher viral loads are associated with transmission. I just don't have a floor to tell you where the cutoff is from the perspective of where it's less likely to transmit.
Okay, thank you. So I mean, it does make a lot of sense to me that the reporting of negative results would greatly enhance the department's ability to do better surveillance and provide more support for treatment and monitoring of hepatitis B. Thank you.
Thank you.
I have a
Ms. Bedlander,
question.
yes.
And I first will acknowledge I'm not a physician, so this might be a simple question. But just so I understand it, I know earlier in the meeting we talked about hepatitis C and that there was a test to determine the status, and then there was a request to do the DNA testing if it was positive at the same time. So is this a similar thing that we're talking about testing people for hepatitis B and seeing that they're positive, and only the ones that are positive get the DNA testing? So we're talking about DNA reports on that are positive or negative for those who are positive with Hep B.
That's right. So
Not everybody who's tested for Hep B.
100% correct. So hepatitis B serology is a bit more nuanced than hepatitis C serology. So for hepatitis B, you'll order usually a trio of 3 tests: a hepatitis B surface antibody, core antibody, and surface antigen. If someone is surface antibody negative and the other 2 are positive, that indicates that they are likely chronically infected or have an infection. And then the next step in that would be a viral load or a DNA test to see what their viremia is like to allow you to make decisions about therapy. So there are, in fact, some other pre-confirmatory steps that are serological that happen in the suite of testing that happens with with just pure serologic testing. The hepatitis B DNA would be ordered. I could imagine scenarios where this may be different in individuals who demonstrate evidence of serologic positivity. One would imagine that it's possible that someone may use it off-label to look for a very hyper-acute case of hepatitis B, but usually they would couple that with serological testing as well.
Thank you.
Thank you.
Any other questions or comments from the board? If not, I'd like to ask for a motion to approve this for publication.
Move approval of publication.
Thank you, Ms. Breyer. Thank you, Dr. Richardson. And everyone in favor, please say aye.
Aye.
I believe that was unanimous. Are there any abstentions or no's? If not, approved for publication unanimously. Thank you, Dr. Tosco. Really been a trend that we ask for both positive and negative test results. It's in a way provides us with the denominator that allows us to track the proportion of tests that are elevated, rather than just keep track of elevation. All right, we're now going to be changing topics a bit and moving on to this is the last item on our agenda today, which is a proposed resolution to amend Article 207 of the Biostatistics provisions. We have a presentation. Please, Mr. Schwartz, you're known to the board, but I would appreciate if you introduce yourself for the record.
Good morning. I am Stephen Schwartz, the New York City Registrar of Vital Statistics. We are asking the board to consider a proposal to move records to the municipal archives, the Department of Records and Information Services. And a bit of background, New York City Vital Records has been in business a long time. One of our first customers was Alexander Hamilton, who unfortunately had a duel in New Jersey, but took a ferry to Bellevue and succumbed in New York City. So one of our first customers in 1804. I started here shortly thereafter. we're talking about birth and death records here. They are confidential records under the health code, and we guard them very carefully. They are active records. From time to time, we have transferred records to municipal archives, but we have not done so on a fixed schedule. So what we're proposing to the board to consider is having a schedule for transfer of records after they are no longer at risk of being exposed to essentially for living people. That's what our concern is. So we are proposing to transfer records of births that are more than 125 years old and death records more than 75 years old. And we would be looking for comments in particular on the 75-year mark, specifically inviting comments on the appropriateness of this period of time versus 50 years, or other years. We'll get into that in a moment. So what are in these records and why are we keeping them so closely guarded? They are personally identifiable information on both births and deaths. They contain detailed demographics such as full names of registrants, mothers and fathers' names, race, ancestry, education, dates of birth, addresses, birthplaces, confidential medical reports of birth and death, including terminations of pregnancy, including abortions and miscarriages that would be recorded on confidential medical reports of birth, and cause and manner of death. So why are we proposing to do this now? Right now, we do not have a schedule, we do not have a rule to transfer the records. The Board of Health has the authority to transfer records and to set a schedule if it so chooses. We are proposing to conform to the Model State Vital Statistics law and to ensure that no personally identifiable information of a person becomes public prior to his or her death. There's also a public interest in these records. So one, and this is a balance of keeping records private and making them available at some point when they would no longer cause harm to the individual. So, for example, amateur as well as professional genealogists have expressed an interest in accessing these records. There are risks of releasing records if we do it too soon. So most people are aware that there are great risks for living people's information getting out there all too frequently. So, and we're also aware that for over 2.5 million Americans over 65, there are a lot of identity thefts. Death certificates have information on living people. And birth certificates must be able to be amended throughout a person's life. The good news is that New Yorkers are living longer. 500,000 New Yorkers are over the age of 75. In 2015, there were 901 New Yorkers who died between 100 and 114, and we should point out that we are always looking for volunteers to live longer and healthier lives. And so during the course of the use of these records, they may need amendments. So For example, an amendment is a correction to a record. An amendment to a record, people come to us to add information so that they can become a dual citizen in another country, say Italy, we get that a lot. So there's a need to have access to those records. Once our records are transferred to archives, we do not control those records and they are not amendable. So it's an important consideration. We recently had somebody walk in, a 100-year-old man who did not have a birth record, prove that he was who he said he was, and we issued a delayed registration of birth. We made him happy. And that's part of our business in public health, is both the responsibility of the retail side of the business, the customer service side of the business, as well as collecting public health records. So, for example, in the last, roughly the last 4 years, we made over 1,000 amendments to records people 75 years or older. Model state vital statistics law provides, last revised in 1992, to ensure that no person's personally identifiable information becomes public prior to a person's death, and recommends that no birth record be released until 125 years after birth, and death records 75 years after death. So why the 75 years for death records? Death records have data on living people. For example, a teenage mother on a death record could still be alive 75 years after her infant's death. That information is on that death record. So infant death records are less common now, but in the 1950s, there were 4,300 infant deaths each year. So the department is very interested in hearing comments on the proposal about how long, especially death records, should be maintained private. And balancing the privacy and the disclosure is very important.
Thank you. The proposal is now open for questions and comments from the board. Dr. Richardson can start off, then Dr. Gatto.
Thank you. It is a pleasure to see you as always. Could you describe for us the differences in the level of confidentiality between records held by the New York State Department of Health and records in the Department, what is it, the DORIS system, what is that?
Department of Records and Information.
Thank you, the Department of Record and Information Services, just so we can understand sort of the level of access, disclosure, confidentiality that we're talking about.
I'm so glad you asked. So for birth records, the only people who can get a New York City birth record is the person named on the record or the parents of that person, of that registrant. And that's it. Very restrictable. Death records are more widely available, so it is close family members basically can get death records under the health code. The records that are transferred to municipal archives or Department of Records and Information Services become public records. So they are completely available. They are, I believe, the Department of Records and Information Services is working with Ancestry.com to make them completely available for a fee and searchable. So it's completely open, and any records that we would transfer, we would be transferring the complete record of the birth or death certificate, as well as the confidential medical report of birth and the confidential medical report of death.
Have a question?
And Dr. Gatto's next, and then Ms. Redlener.
Thank you very much for that presentation. So I think the concern of death records having other person's information on there being released at a time when that person's still alive, I think is an important concern. Has there been a consideration at all of having the release date be contingent on the age of the deceased when that person died? So that someone who did die as an infant might have a longer period before that information would be released, for instance?
Well, we would like comments, and we would anticipate that there would be comments about this proposal. We're concerned because of the risk of information on living people. So how do we don't know that. People in New York City, we'd like them to stay, but they're actually allowed to live anywhere and die anywhere. So we don't necessarily know if somebody has died and when, or where they died. So if we're trying to be most protective of records of New York City, people who were born or died in New York City, we have to be very mindful of what information we have and how we can actually protect the records, other than picking a date that would be protective enough without compromising those people like genealogists and family members who would like to explore that information. So it's a balance.
I think what Dr. Gatt is getting at, if, for example, somebody were age 50 when they died, if the records were released after 50 years, the likelihood that anyone who was listed on their death certificate would be alive would be very, very low. Whereas if they were died at birth, and 50 years later, it's much more likely that somebody listed on the birth certificate would still be alive. So he's I think, acknowledging that there's a different likelihood that people listed on the birth certificate will still be living depending on the age and death of the decedent.
From a practical standpoint, we can only transfer records, all of the records, say of a given year at one time, and not start hunting through them. So the logistics are tremendous. So for us, all vital records offices started out as bookbinding industries and paper records. And the records, so we have paper records, we have paper index books, we have microfilm. Our proposal would be to transfer, for whatever year, all of those records. Just from a logistics standpoint and a practicality and a cost standpoint, it would be most efficient to transfer a given year at one time.
Thank you. Thank you. Ms. Redlener, and were there other hands up on this side of the room? Okay.
Hi, it's very interesting, thought-provoking proposal. I have a couple of questions. One is, could you just explain a little bit more about the model, the state model standards right now? Is that something that most states are implementing relative to the transfer of birth and death records?
The Model State Biostatistics Act and regulations was actually the first model public health law in the US, and I think it was 1905. And so it's in its 6th revision now, last revised in 2011. And it is not a uniform law, it is a model. So it is essentially proposed to states and agreed upon in concert with the National Center for Health Statistics of CDC and the states. So it's voted on that way, and states are implementing it. Some have implemented the 125 and 75, and I think for many jurisdictions, they haven't gotten around to it yet.
Thank you. And another question, I guess, based on your previous answers, probably not likely, but if somebody wanted to protect a birth or death record in their family from public information, would that at all be possible? You know, to you know, whether, you know, this information that a family hasn't disclosed before, you know, if you're talking about birth terminations and that, you know, I mean, terminations. Other, you know, amendments, whatever that might be considered, you know, more, something that a family was sensitive about. Would there be any way of, you know, requesting that they not be made public?
And to clarify, are you asking beyond the 125 and 75 that were, say, to be never made public?
Yes.
I don't know that, I suppose there could be a mechanism created for that. We're always looking for work.
But I think the current answer is no, that the assumption is that,
It's like 1 year.
yeah.
Ms. Breyer and then Dr. Klitzman.
It is always nice to see you, and you always have interesting things to say. So I want to make sure, I might have missed it. If so, I apologize. This Department of Records and Information Services, which is going to receive this material, and it becomes public. And in the process of becoming public, someone realizes that there's mistaken information there, and it can, so once it goes there, I thought you said, believe you said, that that's it. You may not amend it further. That's true? And do you think, I suppose the possibility exists that once it's public, someone who didn't know, that, you know, who's that person or that person's relative might discover something that was not accurate, and it's sort of too bad, right? Is that the deal? To be direct.
Our understanding is that once it's transferred to Doris, they are no longer our records, the department's records, and the only entity that has the authority to amend records or correct records is the Department of Health.
I got it, okay. Thank you.
And Dr. Klitzman, and did I miss anybody on this side? No, okay. And then
Good
Dr.
morning, nice to
Klitzman.
see you, and thanks for injecting some levity into what some people might consider a rather dry topic. So I'll just throw out my question, just to get a better understanding of what's motivating this. To follow up on Karen's question, do you know specifically whether New York State and our surrounding states, New Jersey, Connecticut, have adopted the model laws? That's one question.
So in New York State operates differently. So in New York State, they release their birth records after 75 years if you can prove someone is dead, like a death certificate. And then the birth record could be released. And I believe New York State releases death records after 50 years. We have been in discussion with New York State, which has not looked at that section of their public health law in quite a while. So they are contemplating going along with the new model law of 125 and 75.
I just want to jump in also. One of the reasons that this is being considered now is, I should point out, under the administrative code, the process historically has been that the department could come to the board, given times and just say, release these records, and it's done in batches and not by rule. It was last done before Steve was here, I think, in the 1980s. Why we're doing it now is that there is this interest on groups to get records. I think we need a rule from a perspective of we're going to say no or yes to people's requests for records. It should be prescribed. And so it was really my suggestion that this be codified and it be a rule set for when we're going to make these records public.
Thank you, that was one of my questions. My other question was, you mentioned that you have books and you have paper records and you have microfiche and you have electronic records, so is there a plan to move everything, the older records to electronic, or would they be just transferred in whatever form they're in? And that kind of relates to the manpower question.
We expect it's going to be a challenge any way we do it. So it would be appropriate for us to, it's actually, logistically, we have to move everything essentially at one time. For example, when we imaged all of our, I think in 2006, we imaged all of our birth and death records, about 13 million records. That's the good news. The bad news is we only did the front side, not the back side. So for somebody, if we simply transferred, which might be really logistically easy, by just transferring the electronic records, it would only be the face of it, not the confidential medical report of birth, which is on the back, which would be of great interest to historians. So it's a mixed media challenge.
Okay, I'm gonna give Dr. Richardson first, and then Dr. Caro, and then I think we should be close to wrapping up.
So, do you know, are there any persons currently living in New York City who are over the age of 125?
We know of none. We did have a woman die in Brooklyn 2 years ago at age 116.
Okay, thank you. And is it possible to search the fact of a birth, not get access to the birth certificate, but the fact of a birth or a death in public records if you're not directly related to someone? I'm trying to understand what the sources are now that are open. So, or is the birth certificate really the only source of the fact that someone was born?
That's a great question. When we all started in the business, everything was paper. There was nothing called the internet. So now with the advent of the internet, there's access in many ways, and many people will choose to post their information, maybe placing themselves at some risk by doing that, by putting birth information on there, for example, or death information, and how that might be misused. And there really are risks, and there are also risks of where we get complaints or read about issues where someone will steal an identity. And identity theft is especially practical for stealing the identity of younger people who have died at a young age, because that has the greatest opportunity for using that during a person's lifetime. In fact, we had a case that was adjudicated in federal court where we had to testify about somebody who had stolen a New York City birth certificate and used the identity. So that's a real risk, and anything we do may contribute to the risk and the loss of protection of New York City born or New York City event.
Are census data made publicly available at some point?
Yes,
They're
they are.
searchable,
And-
I think that.
Yeah, and so 1940 census data are available. A really good question. The last time I understand that the census evaluated the benefits and risks of releasing those data, the last time they did that was in 1952. So they're really on top of it.
Thank you. Dr. Cara and then Ms. Gill.
Just a brief question. Is any difference between if a deaf person is not claimed by any family member or in this proposal? Any difference?
We have all of the records. So for any death that occurs, we have that record and they are all treated equally.
Thank you, and Ms. Gill.
How do we protect these records? Of course, we're living in the age of internet, and we just this week have to put out with the notice of Equifax and really the challenge of many citizens' data being exposed. So how do we protect this for even things that we are not even aware that they can be used for? But it's mind-boggling to know that 143 million people in the United States, their data is gone, and we don't know how they're going to use it for. So that's my concern.
And we share that concern. So we build electronic systems that are very tightly controlled within our own offices. How we keep them, store them. We also have to be very concerned about how those original records are generated, because a birth record endorsed by New York City creates a US citizen. So we're really careful about how we are using biometric devices for, and now we're going to facial recognition for all of our providers who are sending data to us. So we are trying to keep as ahead of the game as much as we can, and New York City also works with all the states to learn from each other to do the best we can.
All right, if there are no further comments or questions, I'd like to thank the board for a robust discussion and ask for a motion to approve for publication.
I move
Dr.
approval
Gauda.
for publication.
Okay, Dr.
Second.
Richardson seconds. And may I have all in favor, say aye.
Aye.
Passes unanimously. Thank you. Approved for publication. All right, with that, I'd like to thank the board for a very packed meeting and a very rich discussion, and declare the meeting adjourned. Thank you.